Thank you for joining. Today I'd like to introduce both of our speakers, Dr. Barbara Srichai. Dr. Srichai is an associate professor of medicine and radiology and is the vice chief of the Georgetown section of the MedStar Heart and Vascular Institute and the director of Georgetown's cardiac non-invasive imaging laboratory. And Dr. Zeck, who's also joining us, he's an associate professor of pathology and the medical director of laboratory medicine. He also serves as the program director of the Cytopathology Fellowship. Thank you both for joining and look forward to learning about high sensitivity troponin.
Thank you, Sean. First, I thought we'd start with just a case study for consideration. 50-year-old African-American lady presenting with headache and non-radiating chest pain for 2 days. She came to the ED. She has a past medical history that's significant for antiphospholipid syndrome, for which she's taking Lovenox. She also has Crohn's disease, a history of multiple CVAs, migraines, and hyperlipidemia. On presentation, her EKG showed normal sinus rhythm with no acute ST abnormalities to suggest an ischemic etiology. Her first troponin value was less than 0.015 nanograms per milliliters, and her heart score was 3. And so just kind of want to put that into the background kind of as a clinical context. So we're talking today about cardiac troponins. So what are troponins? Troponins are a group of proteins that are found in skeletal as well as heart muscle, and they help regulate muscular contraction. The regulatory complex is composed of basically 3 subunits, troponin T, I, and C, and it controls the calcium-mediated interaction between actin and myosin. Troponin T and I have actually unique cardiac isoforms, so that's what you usually hear when we talk about cardiac biomarkers. Troponin C, though, shares isoforms of skeletal muscle, so it's not really used as a specific biomarker for cardiac imaging, or sorry, for cardiac evaluation. The troponins are complex about 95% of the time with actin, and then there's a cytosolic component in about 5%. So just about the history of myocardial infarction and the definition. So it's changed over the years. A general worldwide definition was first established in the late 1950s from the working groups of the World Health Organization, and it was a primarily ECG-based definition. We didn't really have cardiac biomarkers at that point in time. And then that definition was refined over the next 40 years. With the introduction of sensitive and specific cardiac biomarkers, ESC and ACC collaborated to redefine what myocardial infarction means, and using both a biochemical and clinical approach to the diagnosis and definition. In 2007, the universal definition of MI consensus document came out, and they introduced an MI classification system. And so you may be familiar with the different 5 subcategories that we subclassify myocardial infarction into. And then with the development of more sensitive biomarker assays, this universal definition of MI has been further refined, and now we're at the 4th universal definition of MI. Just a little bit about the historical timeline of cardiac biomarkers. You can see that biomarkers were used in the 1960s, but they were pretty nonspecific until the development of the troponin assays in the 1990s. And initially it was with troponin T and then with troponin I. So high sensitivity troponin assays have been developed and have been actually in use since 2009, but primarily outside of the US. Its availability within the US has really been only in the past 4 to 5 years. So there is a wealth of data on high sensitivity troponin, but mainly non-US studies, mainly non-US sites. But we're seeing a steady increase in its adoption in the US. So just a little bit of terminology. So the definition of myocardial injury, it's defined as the presence of blood levels of cardiac troponin that fall above the 99th percentile upper reference limit. This injury we usually define as whether it's acute or chronic, and that's dependent upon whether we see a rise and or fall in the cardiac troponin values. And on the other hand, the definition for myocardial infarction, the clinical definition now, indicates we need the presence of an acute myocardial injury as detected by these abnormal biomarkers, but in the setting where there's evidence for acute myocardial ischemia as well. And so we can see here that there are a lot of causes for myocardial injury, i.e. there are a lot of causes why your troponin values can be elevated. And myocardial infarction is just one aspect that can lead to, that can be an etiology for myocardial injury. But we have to take into account a lot of other etiologies, which I've shown here, contributing to either an acute or chronic elevation in the troponin values. So I'm just going to give you a little bit about what we've been doing and how MedStar has been working to deploy this high sensitivity troponin. When it became known that we are moving towards the high sensitivity troponin within our laboratories, Dr. John DeSimone created this high sensitivity troponin working group and incorporated physicians across the MedStar system, north and south, from different departments, including laboratory pathology medicine, cardiology, ED, hospitalists, and critical care. With this group, we reviewed the literature on the current use of high sensitivity troponin, and we reviewed experience at sites in the US that were using the troponin, the high sensitivity troponin. Our plan was, once we had new analyzers, which Dr. Zeck is going to go a little bit more into, that we would do a mini validation, both of the recommended cutoffs for our population, as well as devise a protocol for how MedStar will, how our group will deal with the high sensitivity troponin values that we're going to be seeing and how to manage our patients as a result. And this is just the starting point, because we really don't know where we're going with this, and we plan to take our data that we get once we start off the ground running and refine the numbers after collecting additional information once we go live. Great. I'm going to switch over to Dr. Zeck.
Good afternoon, everyone. So just kind of a quick word from your clinical lab and the laboratory perspective to just kind of give a little bit of context regarding this transition. The question is probably why now, right? Why the switch now? And the answer truly is that our laboratory chemistry analyzers, like everything else, has a shelf life. And we had been working really for the better part of over a year to bring online these new instruments into our system. And it's happening here first at Georgetown. You can see that our planned go live date here is June 2nd, but then will happen at later dates throughout the MedStar system. And one of the opportunities in that transition was to switch from our conventional 4th generation troponin to the 5th generation high sensitivity assay. So of note that upon that transition, the conventional troponin will no longer be orderable, and that'll be in order to reduce confusion, and that the new power chart order itself, you can see here, will be troponin I and noted high sensitivity. This is a look at what the actual platform looks like. It's actually the size of maybe a small car. It's kind of our workhorse instrument in the laboratory. It runs currently about 2.5 million tests we run in clinical chemistry. So you can see it's a very high throughput instrument. There's about 200 tests that we are currently available on this instrument, including the high sensitivity troponin. As always, troponin will be a result that will get out to the clinicians within less than 45 minutes, and that part will not change. Currently, the MedStar troponin assay is one that looks for troponin I, and the lab principle behind that will remain the same. So this is actually a antibody-based assay. And it will be as well for the high sensitivity assay as well. It's just that it will be with much greater sensitivity. Of note, an international organization that standardizes these things had come up with 2 definitions for what high sensitivity means for a troponin assay. One of them is that when the 99th percentile value is established, and you'll see, and we'll mention the ranges here in a moment, that once that percentile value is established, that the imprecision is very low at that threshold. And also, and this is a divergence from the conventional troponin, whereby greater than 50% of healthy individuals are actually above the lower limit of detection. Whereas right now with the conventional troponin, most healthy patients have values that are below the limits of detection. And this is just to illustrate at our 99th percentiles, which is defined as 34 for females and 53 for males, that if it were an imprecise test, we would have variability, too much variability at that threshold. However, because it's a very highly sensitive assay, by definition, we have very reduced variability if we were to repeat that assay many times at these particular thresholds. So just a few points about the transition. The units of measure are going to be different. So rather than nanograms per milliliter, it's now going to be nanograms per liter. The lower limit on the instrument is going to be defined as less than 3, and the upper limit is clearly very high. There's no change in the collection tube. It's going to be a dark green blood tube, which is a heparinized tube, and that's going to remain the same. It should be noted that high sensitivity troponin should not be directly correlated with conventional troponin assay results. And so that you should not plug in high sensitivity numbers into conventional algorithms. And lastly, although it's not encouraged, troponin can remain to be an add-on test. And if anything, the high sensitivity troponin assay is a bit more stable than our current conventional one. Just a quick note on limitations and interference. This is actually very similar as to it is now in terms of some antibody-related interferences are potential or possible, although they're described as rare. That's in patients that may have very high immunoglobulin levels, patients that are on specific monoclonal therapy treatments, or if there's rheumatoid factor or heterophilic antibody interferences. Again, the data is still being collected on the high sensitivity assays, but if anything, they suggest that these interferences are less than we're seeing currently with the conventional. One very nice positive about the high sensitivity assay is that the interference with biotin is now almost negligible, given that patients that have even very high doses of biotin on board, we wouldn't see interference like we do now with the current conventional troponin assay. And also, this assay will be very stable even in significantly hemolyzed samples. And lastly, this is just when you do receive results on a patient with high sensitivity troponin, the female reference range will be 0 to 34, the male reference range will be 0 to 53. Of note, by convention, only whole numbers are used, and that's what will be reported. And you can see that our old reference range here, the upper limit for normal was 0.45. Dr. Srichai will go in-depth here regarding the algorithms, but just to note that with every high sensitivity troponin result, you will get this kind of mini interpretive comment that includes much of the algorithms.
Because you had rheumatoid factor up there and some other antibodies, will those cause false negatives or false positives in this assay?
Yeah, that's a great point. So both of these, rheumatoid factor and heterophilic antibodies, these are antibodies that are directed towards certain components of IgG. And the trouble is that antibody-based tests clearly utilize antibodies that have these parts and factors with them. Many times there's a clue in the laboratory that it would be on the instrument that there is an interference, and we may be able to dilute out the sample in order to get rid of the interference in these cases. So it might be something that would be that essentially goes unseen to the clinic because we're able to deal with it in the laboratory. But to your point, these are relatively rare, and if anything, are a little bit more improved in the current assay as compared to the old.
Thank you, Jay, for going over the laboratory aspects of the high sensitivity troponin. So the biggest concern that a lot of us as clinicians and cardiologists have is that with the high sensitivity troponin, now we have an increasing number of different conditions where the troponin can be elevated, not necessarily just myocardial infarction. And, this is like a quote from an emergency room physician. When the troponin was a lousy test, it was a great test because it really only picked up MIs. But now that it's a great test, a great assay, it's actually a lousy test because it's picking up everything else. But just one comment and just one slide about elevated troponin levels and outcomes. In this study, which pretty much we've seen in a lot of different conditions, higher troponin is, a higher troponin value is worse than a lower troponin value. And in this study, which included patients who had actually troponin values that were in the normal range, you can see there's still a gradation that the higher the troponin value compared to the lower ones were associated with increased outcomes or worse prognosis. All right, so now that we have all these different conditions and it's not just myocardial infarction, the clinical context now becomes critical for interpreting what these values mean. We're going to see more quote-unquote positive results, so that's why this is important when we're making our decision about how to manage our patients, and we can't just rely only on the test as had been done probably in the past. So we have to look at things like, are the troponins chronically elevated? Is there an acute rise or a fall in the values? Does a patient clinically have symptoms that are suggestive of an acute coronary syndrome, or is there any other kind of objective evidence for ischemia? In this graph on the right, we can see that the difference between a patient who may be presenting with acute myocardial infarction, where we have a kind of predictable rise, and then a usually slower fall in the troponin values, whereas in patients with chronic myocardial injury, we would see kind of a slow, elevated troponin value that kind of doesn't really show a rise or a fall. With the high sensitivity troponin I values, for samples that are drawn 2 hours apart, a significant, a change of at least 20 nanograms per liter is considered to be a significant change and is probably most consistent with an acute injury going on. We might also see a decrease in the troponin levels over time that can indicate that maybe that you had a recent acute injury, but this is less specific. And then chronic conditions, it really rarely should improve and increase in the a significant change in that troponin value over the time intervals that we're talking about, 2 to 6 hours. So in developing an algorithm for acute MI evaluation, of course, troponin plays an important role, but clinical evaluation, their clinical symptoms, their vital signs, as well as the EKG, play vital important roles in determining whether or not we think this patient is having acute MI and what our triage decision will be. So I mentioned earlier that as part of the MedStar deployment, we had decided to perform a validation project before deciding on an algorithm that we would use going forward or to propose going forward. As Jay had mentioned, our high sensitivity troponin values, we can't use prior algorithms that are out there using conventional troponin. So we have to go on to the newer algorithms that utilize high sensitivity troponin. But just to take you on the journey of what we've done over the past year, about a year ago, when we decided to perform this validation project, we had decided maybe 200 to 300 patients we would just collect samples on, see what our conventional troponin values are, and then when we had the new analyzers to see, well, what happened to those patients and what did their high sensitivity values show. So about 350 samples were frozen. Over the following 2 months then, there was a collection of the clinical data on about 200 patients. And I have to give kudos to Haley Harvey, one of the ED residents, and John DeSimone, because they did the bulk of all this clinical data collection. I should mention also that the sample, so this was all performed here at Georgetown, and it included patients from the ED, from the inpatient units, including the ICUs, as well as outpatients. So it was pretty much all comers, although the bulk of the patients were from the ED. Around September, we finally had the new chemistry analyzer that was installed here at Georgetown. And then over the next several months, Dr. Zeck and his group went on validation of a lot of the different other, besides troponin, but the other kind of chemistries that were being updated. But in addition to that, the troponin I measurements. In February, we finally thawed our frozen samples once we had the validation and were analyzed. Over the next few months, we analyzed the data that we collected and went through the literature in terms of different algorithms that were out there to see which one would best match with the data we have here at Georgetown. We had anticipated that we were going to go live sooner than we are, but unfortunately from March until now, COVID-19 interrupted our operations. And now our go live date is planned to be June. So I'm not going to bore you with all the heavy details with everything we did in coming to this proposed algorithm, but just to let you know that this algorithm is based on a published protocol that was developed on an ED sample of over 1,700 patients from 5 different countries. They were all from the European countries, I do have to say, so not necessarily from the US, but out of the different algorithms that were out there, this one seemed to match our data set the best in terms of providing a sensitivity and specificity that we are comfortable with. And I'm just going to quickly walk you through this algorithm that we have devised here. And again, this is just a starting point. So I don't want anyone to think that this is where we're going to be a year from now. This is where we're starting now. As I mentioned, we plan to collect additional data as we go live to see about making refinements to this algorithm. So this is, again, the starting point. But if a patient that you suspect has an acute cardiac condition or suspected acute coronary syndrome, if we go to the left side here, if they've had symptoms for at least 3 hours and that first troponin value that you get is 3 nanograms per liter or less, then we can consider them to be essentially ruled out. It's very highly unlikely that they're going to have an underlying acute cardiac injury, and you can see the sensitivity specificity data there. If, however, that first troponin value is above 120, then they probably have some underlying acute myocardial injury, and we're going to consider them to have rolled in and need further evaluation and probably cardiology evaluation. Now, everybody that falls in that middle range between 3 and 120, you see falls into this middle group, or if their presentation has been less than 3 hours, and then we're going to recommend that you send a second troponin at 2 hours. And again, coming here on the left side of the screen, if that second troponin, when you compare it to the first troponin, if that change is less than 7 nanograms per liter and that first troponin was less than 8 nanograms per liter, then we have pretty high confidence that this patient does not have an underlying acute myocardial injury, and we're going to consider them to be ruled out. If, however, that second troponin value shows a change of at least 20 nanograms per liter from that baseline level, the likelihood of an acute myocardial injury is very high, and we're going to consider them to have been ruled in and need to be further evaluated. Now, everybody else kind of falls in this gray zone if they don't meet either of those other 2 parameters, and it's recommended that we observe these patients and sort of do what you normally would do. This is where we might consider doing repeating the troponin values, observing them, doing further cardiac testing. So just a reminder that just because you have an elevated troponin value above the 99th percentile, we're calling that myocardial injury, and myocardial infarction is a subset of myocardial injury. There are a lot of different conditions that can be associated with myocardial injury and infarction, but again, this myocardial infarction is just a subset of this. According to the most current 4th universal definition of acute myocardial infarction, you need a rise or a fall in the cardiac troponin values, with one of the values being at least above the 99th percentile, and at least one of the following: either symptoms that are indicative of acute myocardial ischemia, new ECG changes that are suggestive of an ischemic etiology, development of pathologic Q waves, or imaging evidence either of new loss of viable myocardium or a new wall motion abnormalities that suggest this is an ischemic etiology. And once, if we've decided this is a myocardial infarction, most are going to fall into either type 1, where there is a thrombotic occlusion, or type 2, where it's more of an oxygen supply-demand imbalance. In this article, they show that actually the degree of troponin elevation can also help predict the cause. Similar to what you do with the normal troponins, those with very high levels, again, is more indicative of having a larger infarct. And we expect that healthy individuals will be lower than those who have stable angina or subclinical heart disease, and will probably hopefully fall below the 99th percentile. We just have to get used to this change in the units here. And so again, this is kind of an algorithmic approach in terms of diagnosis. So you have a patient who has an elevated troponin value above that 99th percentile. If the troponin levels are stable, it's more likely indicative of chronic myocardial injury, which can be seen in underlying structural heart disease or chronic kidney disease. If it's associated with either a rise or a fall, then we need to figure out, is this an infarction or just a different type of myocardial injury? If there's evidence of ischemia, then it's most likely an infarction pattern and either a type 1 or type 2. And if it's just, if there's no evidence of ischemia, then we're talking about an injury pattern, such as can be seen in myocarditis or acute heart failure. So what about the heart score? The heart score is used a lot in our ED and in other EDs throughout the country. It's interesting because most of the algorithms that we evaluated did not actually incorporate a heart score. And with personal communications, a lot of other clinicians out there weren't sure how to incorporate the heart score into the high-sensitivity troponin algorithms because it seemed to have less value. It's unclear, though, because we don't really have prospective studies using the heart score. And also, we would have to use what we call a modified heart score because the current heart score relies on conventional troponin, fourth-generation troponin numbers. With the high-sensitivity troponin numbers, some institutions have used either a HAR, H-E-A-R, without using the troponin value, or in this case, a modified heart risk score. We plan to continue using this modified heart risk score and collecting data going forward to see if it is going to have a prognostic role or not, particularly maybe in that gray zone patient, those patients in that gray zone where we're not sure because they don't definitively rule in or rule out. What about cardiac imaging? When would we use that? So it can help us when we're trying to figure out if this patient is having an acute myocardial infarction. Again, if there's imaging evidence of either loss of viable myocardium or a new wall motion abnormality. It may be helpful in that gray zone area that I showed, where we might consider doing either stress testing or coronary CT to further risk stratify the patient, depending upon what the underlying clinical scenario is. It may be helpful to distinguish if we know a patient has injury. We don't really want to do a stress test because there's injury pattern there, but we're not sure if this may be myocarditis or not. Maybe a CTA to look for underlying CAD versus an MRI to evaluate ischemic versus non-ischemic causes. And then also, we might want to do imaging just to look for non-coronary, but cardiac pathologies that can be associated with chest pain. So other additional considerations, patients that we will probably see and have to think about when we're doing the high sensitivity troponin, patients who we think may be reinfarcting. So their troponin is already elevated, but it's stable or it's decreasing, but now we think the patient's having another infarction. The guidelines recommend that you should have at least a 20% increase in that second sample over the sample prior in order to consider it to be positive for a reinfarction. With procedural myocardial injury, like with TAVRs or ablations, the extent of injury can be assessed with serial troponin, similar to what we do now. In patients with concern for perioperative MI, just to let you know, as many as 35% of these patients may actually already have a level above the 99th percentile. So it's important if there is a concern that this patient may have a peri-procedural MI to have a baseline level performed before surgery. And this, again, is in the case of the high sensitivity troponin. It's been reported that up to 17% can have signs of an elevating or rising pattern with these values. What about the heart failure patients? Again, similarly, there are a lot of patients with heart failure will probably have a level that is measurable, and a significant proportion of them will probably be above that 99th percentile. Again, it's going to be the acute rise or fall to suggest whether or not this is an acute heart failure exacerbation and or myocardial infarction. And so we'll have to use our clinical acumen in addition to the troponin values. With Takotsubo cardiomyopathy, again, we usually see the transient elevations similar to what we know now. It's usually not as high. It's usually more modest compared to that of type 1 MI. And then kidney disease, similar to those with heart failure, the majority of patients who have underlying chronic kidney disease will probably have an elevated troponin value above that 99th percentile. And so it's going to be, again, the serial changes that are going to be important to effectively diagnose MI in this population. At present, there's no data to suggest that we need a different cutoff value for either of these other populations. All right, so going back to that first case, that case that I presented to you, the 50-year-old lady who presented to the ED with chest pain for 2 days and headaches, with the initial troponin that was below the detection level, less than 0.015, and a heart score of 3. Her X-ray showed a mild increased interstitial prominence, but it was thought to be just artifact due to the technique. She was admitted to the internal medicine service and had repeat troponins because she was having persistent chest pain and also for management of her migraine. As we can see here, she had troponins repeated twice over a 17-hour period, and they were all below the level of detection. She did get an echocardiogram that showed normal LV function, no regional wall motion abnormalities, and was eventually discharged home with no further events. If we look at what her high sensitivity troponin values were, they were actually all also below that lower limit of detection. And given that her symptoms were over 2 days and she had a really, really low level of troponin, we probably didn't need to, her chest pain was, as was concluded eventually, not cardiac related, but we probably could have ruled her out with just that baseline troponin. A second case, just for consideration, a 59-year-old African-American lady with a couple of risk factors for coronary artery disease. She actually hypertension, hyperlipidemia, with a history of an MI in 2011, and coming in with intermittent chest pain over 3 days, sort of a classic pattern of chest pain, substernal going to the neck and arms, associated with dyspnea, nausea, and mild diaphoresis. However, some atypical findings as well, improved the sitting up and slightly with Maalox. She was on dual antiplatelet therapy already because of her MI in 2011, as well as a statin and a calcium channel blocker. She did have a cath from 2011 that was obtainable and reviewed and actually showed insignificant coronary disease, despite her risk factors. Her EKG showed normal sinus rhythm. She had LVH by voltage, but no ischemic changes on her EKG. And her initial conventional troponin we see here is 1.1 nanograms per milliliter with an elevated heart score of 5. So her X-ray also showed no acute cardiopulmonary abnormality. She was admitted for observation given the elevated troponin value seen there. She had a second troponin value done 3 hours later that showed that was at 1.020, so a little bit lower than the initial one. She had an echocardiogram that showed normal LV function with no regional wall motion abnormalities. And as I mentioned, the cath from 2011 was reviewed, and given that that showed insignificant CAD, it's a flat troponin, no ischemic changes, and normal echo, it was decided that she could be discharged home and with a plan for cardiac MRI to evaluate for sort of a myocarditis picture and or prior scarring. Of note, the dual antiplatelet therapy was stopped. She was just sent out only on aspirin. These were her high sensitivity troponin values, and you see that she, again, was in a high range, 674, and the second one was decreasing, and we see that there was a significant change there, and suggested that this was probably an acute injury pattern. still a little unclear as to the etiology. Just for interest sake, she did have an MRI that was about 3 weeks later, showed that her overall function was normal, but she did have evidence of an infarct, a subendocardial infarct, and suggesting that this was more consistent with a coronary etiology as opposed to myocarditis. She underwent a CTA that actually then showed no significant coronary disease, but was consistent with a small area of infarct at the basal inferior wall. Given the two findings there, she was actually restarted on dual antiplatelet therapy and was felt to probably have had an acute coronary syndrome at the time of her presentation, that probably late presentation. She was referred to hematology for evaluation of hypercoagulable state and had cardiac monitoring to look for possible occult atrial fibrillation with question of embolic source of her acute coronary syndrome. All right, so just some summary take-home points here. As Jay mentioned, the start date for the high-sensitivity troponin here at Georgetown is going to be June 2nd. Washington Hospital Center and Franklin Square Hospital are actually to follow this summer. Just a reminder that the units are going to change. So they're going to be reported in nanograms per liter. So what we normally see as 0.045 is now going to be reported as 45. What's normally seen as 0.120 will be seen as 120, and 1.010 will be 1,010. The lower limits of detection are changed as well. What we're used to seeing with the conventional troponin is a less than 0.015 nanograms per milliliter. That corresponds to, on our new scale, of 15. Our new lower limits of detection now is less than 3 nanograms per liter. For patients who are presenting to the ED, we have now implemented, or we're going to be implementing a quick rollout if they have symptoms for at least 3 hours, and that first troponin is less than or equal to 3 nanograms per liter, then they will be considered to have been ruled out and no further testing needed. Of course, in this preliminary phase, if there is still concern that that the patient, because of other considerations, may still have an underlying cardiac condition, of course, we would fully evaluate that. But I think this lower limit of detection leads to quicker rollouts and higher confidence that the patient's symptoms are likely not cardiac. We will probably have more false positives for ACS evaluation, and as I mentioned earlier, we're going to have to rely more on clinical assessment. The other thing with the high-sensitivity troponin is that the serial changes, or these delta values as they're called, are going to be important for management. And we've designated a 2-hour change of at least 20 nanograms per liter is going to be considered significant and suggestive of an acute myocardial injury. And then finally, acute MI, the diagnosis is going to depend on the labs as well as the clinical assessment. I think that's my last slide. Yeah. So I don't know if there are any questions.
Just want to follow up from Dr. Zeck. He said that per the manufacturer, the potential interference of antibodies is actually variable. So you may get falsely elevated or you may get falsely negative results. So there's not a consistent trend. So just keep that in mind if you have patients with high titer rheumatoid factor, multiple myeloma, or other polyclonal gammopathy situations. Any other questions from the group?
It looks like there was one in the chat window from Dr. Fisher.
If you have an admitted patient who has acute chest pain while they're an inpatient, should the troponin only get drawn 2 to 3 hours after the pain starts?
So usually we send them at the time of the chest pain, and then we're going to recommend that you get another one 2 hours later.
Okay.
The quick rollout is really for the ED.
And then we have another question. Since cardiac CTs and MRIs may be needed for indeterminate values, do we have the capacity to do this in the emergency department?
So for indeterminate, I don't know if I specifically said that we would do that for indeterminate, but I mentioned about CT. We do have the capacity for CT. For MR, that's a bit more tricky. For MR, it was more for if there was an injury pattern and we weren't sure if it was myocardial infarction or something like myocarditis. then we might consider an MR in that sense.